such a huge part of the band's success. Not a bad-looking guy either. Cleveland is Ben's hometown, and they've always been very proud of him here. And I know that wherever he is, he's so proud on this special occasion, and even more so that it would occur here of all places. To my wife, Jill, who's in this business of ours as a senior VP at A&M Records, and my daughter, Sydney, your love, support, and patience in putting up with the life of a musician has meant more to me than I could ever express in words. I love you both to the moon and back. Finally, that's right. Finally, to my mom, a Juilliard-trained singer who's incredible, on a level with a Garland or a Rosemary Clooney, and gave up a career to raise a family, but who gave me the gift of music and let me pass that gene on to my daughter, who's an amazing singer. So you might say that music is sort of the family business. My mom was my biggest fan and shared in the joy of our success, and I always felt like I was doing this with both of us. And I know that she's smiling down at me from wherever she is, and is so happy and proud tonight. We did it, Mom! Thank you all very much. That statue is too heavy a burden for me to hold. So in 1964, I was 11 years old, and I'd been taking piano lessons for three or 4 years, and frankly, I was kind of getting bored with it and wanted to give them up. But one day, my dad came home and said, well, I've got tickets to go see the Beatles. But if you want to go, you've got to sign up for another year of piano lessons. Back then, I thought that was a pretty good deal. And I still think that's a pretty good deal. So, I'd like to thank my dad for that pretty good deal. And the other side of the story is that I have to acknowledge that if it weren't for the Beatles, I don't think it ever would have occurred to me that I wanted to be in a band. I'd like to also say thanks to
Gr- Greetings, Ahmed and Bekthoni. Hello, can you hear me? Hello. You gotta unmute. Hello, Ahmed. How are you?
I'm fine, and you?
Okay.
I just tap this. I don't know what this button do. Like
No,
raise hand.
You don't do. You're on the panel. I guess you're a med student, right?
It's the first time for me
Okay, no problem.
because
Okay.
my friend Ali will present this lecture
Oh,
after me.
excellent. Okay. You need to turn your camera
Okay.
on. You have a camera?
Yes. Okay.
Yeah,
Hold
turn
on.
that on. You have a smartphone, or are you using a?
Yes, smartphone.
Okay. Oh, there you go. Hello. You
Hello.
see, the physical is it means a lot. It's not an email. It's not an old video. It's a live human
Yes,
interaction. It means
it's
so much
interesting.
more than an email.
Yes. Thank you.
So nice
So
to
you
meet you.
always present like this.
I'm sorry.
You always present like this lectures every
Yes,
day.
yes. Not every day, but a couple times a week. We're getting more. This is the first iRAQ presentation. We do Jordan grand rounds every Wednesday with a big neurosurgeon from Jordan. His name is Ibrahim Sabeya, the big
Oh,
skull base guy. Uh, and let's see. We do an African one later on today with 3 presentations, a journal club and 2 other
yeah.
presentations. So,
I already serve your website. I saw many faces from many countries.
yeah, it's
Who
a global community. I mean, and the
very
internet
interesting.
is a perfect tool. It's a global tool. You could be
I'm
next
the first.
door or Pakistan.
It's very interesting. I'm actually third medical school at the University of Baghdad, the same University of Ali, who present this.
Oh,
Who will
good.
present this?
Excellent. I hope we
Is
have a good crowd.
my best friend.
Good. Yeah, all you do in the panel is just like being in a lecture in the hospital. You sit there, you could be quiet, or you could you could ask a question, or leave
Uh-huh.
early if you have to go see a patient or an emergency or whatever. So it's just like a conference in the hospital. That's essentially what it is.
Yes. Okay, I'll experience it.
Yeah, it can take all forms. It could be pure lecture, could be more interaction, could be multiple presentations. It
Uh-huh.
depends, but generally it's a presentation, a PowerPoint that lasts anywhere between 20 to 40 minutes. And then
Uh,
if there's some panelists, sometimes it's just a couple, sometimes it's a lot. We always try to introduce everyone because networking is a very powerful part of this platform. Meeting people, meeting neurosurgeons, which will be very useful in your career. To go to another
interesting.
hospital, to collaborate on a paper. It expands your community of neurosurgeon friends and acquaintance.
Good.
So
So
besides your hospital,
this is like a competition
yeah,
between competition.
no, it's not a
Yeah.
competition. It's
Just a
just
presentation.
conferences. That's all.
Just conversation.
Yeah,
And
it's just
all the
conferences.
conversation is saved on YouTube, so I can
Yes, they're
check.
all on the. You could download the app, Neurosurgical
I
TV.
already downloaded. I
Okay,
downloaded it from the app.
there's a page, YouTube channel. It's
Zoom.
all the videos we've done. One of the 5 pages. Go to you go there now. Go. Oh, you can't now. You're on with me. But I mean, when you get a chance, hey, I'll do it right now. We're working
So
on it.
can I participate it in this conversation if I have an interesting topic to talk
Yeah,
about.
of course, of course.
I
I'd like
just
to start a Pakistan Grand Rounds.
So
I would
how
like to.
can what is the requirements or to
Well, just a
participate?
passion for surgery, neurosurgery.
Passion
Well,
for any type
passion,
of surgery.
neurosurgery.
Surgery?
Neurosurgery right now, we're concentrating on neurosurgery.
Yes.
Yeah.
So the
So
background.
anything that you would present at a conference is what you could present online.
Actually, I'm 30 grade. I'm now general. I don't have any.
Yeah, well, it could be general. It could be general, which applies to most neurosurgeons and students. Just a general topic. Just let me know a time. And just like this one, people got together and says, "Hey, let's do a presentation. Let's do a grand rounds." So
Interesting. Very interesting.
yeah. Well, listen, I gotta get going because I gotta get some things ready.
Okay. Take your
You
time.
can just sit here. We start in about a half hour.
Okay. Thank you.
Okay, I'll be back.
Okay.
Partage d'écran, rejoindre l'audio, inviter d'autres personnes, sujet de la réunion, animateur, copier l'URL, numéro de participant, numéro 38. Numéro 38.
Okay, Samar, hi.
Hello, Dr. John.
How you doing?
I am Ali. Dr. Samar will come in a few minutes.
Well, I said I didn't look. Yeah, of course. Okay,
Yeah.
okay. Let me get off the. There's another screen I'm on. Hold.
Okay.
Yeah. 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 When you're on two, like if I'm also on the Zoom screen, I mean the YouTube screen, it's a delay of 15 seconds. So when you have it open in the same computer, it screws up. Anyways, you're all set. You know how to screen share. I guess Sammer showed you how, right?
Yeah.
Okay. You want to do it again? Or try it again, or you're all set?
To present or make the presentation on the top here.
No, if you want to practice screen sharing, because we got a few minutes till we start.
I will try it. Right. I will try it right now. Okay.
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 Yep. There you go.
Just a few minutes.
Okay. Then you make it bigger, right? There you go.
Now it's good for you.
Yeah, you make it bigger. At the bottom, there's a couple options there. Explore that.
I will try.
Yeah. Okay.
Okay.
I think it's at the bottom. One of those options. Yeah. One of those. Try one of those. There you go. You see how big it is?
Now it's okay or
Yeah.
not?
Now it's full size. Yeah.
Okay. Thank you.
Okay. And to go to the next slide, I guess you just click it.
Okay.
Okay. You see
Like this?
You see it? Okay. You go backwards
Yeah.
at the bottom left. There's an. Yeah. There you go.
Yeah.
There you go. Very good. And to get off it, you know how to get off it, right?
Yeah.
Okay. Very good. Is Sammer available or is he tied up?
He will come after a few minutes. I think so.
No problem. No
It's
problem.
okay. Yeah.
Yeah, it's on the front page of the app.
Yeah.
Now, listen, that's why I made the app, because I want to make it convenient for people to watch a live broadcast. So when you open the app right now, it's there. It's right on the front page. Like I tap the app to open it. Let me stop screen sharing there.
Okay.
Yeah, I'll boot you off more or less. Okay. Okay. Now on my smartphone, I don't know if you can see it with the camera, but anyways.
Yeah, I see. Yeah.
Anyways, if I start it on the app with one tap, with two taps, there we are. They're live. You can't see that, right?
Yeah.
Okay, we're live on the app. I mean, right now as we're speaking, I haven't started recording it but I mean, hopefully once we get rolling, people will know to see the live presentation. You just tap on the app twice, you see it. So hopefully that'll, but we're not really looking for huge numbers now. We're just a neurosurgery community, you know.
Yeah.
And most people aren't interested in it. Let me make sure I get everyone in here.
Okay.
Okay. Your first name is Ali, right?
Yeah, it's my first time here.
Med student. What year are you?
I'm fourth grade medical student.
2 years?
Fourth grade.
Your first year?
Fourth grade medical student.
Okay, I'll just say med student. My hearing's not the best.
Thank you.
And, but thank goodness I got headphones. So, okay. And yeah, this is going to be fun.
Sure.
So I guess we might as well start. Are you guys the panelists there? There's a couple of panelists we have. I guess one of them's your buddy. When Ali is speaking, of course, stay muted. But when you want to ask a question or make a comment, unmute. Okay, all the panelists. Okay. 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 Very good. Okay, might as well start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach. We have the pleasure today of having Ali, a medical student from Iraq, who's going to do the first groundbreaking grand rounds from Iraq. We hope it's a regular presentation. And before we meet Ali, let's go around to the panelists to see. Okay, the panelists. Ahmed, are you there, Ahmed? He may have stepped away.
Yeah. Now I have to start.
Hold on. Let me see if there's a couple of panelists. I don't know if
Okay.
Tuka, are you there?
Partage.
Bethany, are you there?
Diffusion.
Yes, yes, I'm here.
Yes. Could you please introduce yourself and put your picture on if you
My name
can?
is
If you can, you got a picture there, right?
Okay.
Yeah, you're not on there. You know, your face is not on yet. There you go.
No,
There you
no.
go. We want people to meet you. Yeah, just tell us about
Okay.
yourself and where
My
you're
name is-
practicing. Okay. Go ahead.
Okay, my name is Ahmed. I'm a friend of Ali, the medical student at University of Baghdad, third grade. I'm now participate with you because Ali is my best friend and I attend this lecture.
Very, very good.
Okay.
Welcome, Ahmed. Okay, I guess we'll meet the other panelists later. Okay, Ali, welcome. And why don't you just briefly introduce yourself and then on with your presentation, and welcome.
Hello, John. How are you?
So I close my mute.
Okay, right now.
Okay, go ahead.
Okay.
Very
Hello, everyone. My name is Ali Mohammed. I am fourth grade medical student at College of Medicine, University of Baghdad here in Iraq. And I am super highly interested of the neurosurgery department as my future career or my future specialty. And today we will present our lecture here, the spontaneous subarachnoid hemorrhage for non-neurosurgeon. I hope so. We will get the benefit and have some fun together.
Very good. Okay, on to your presentation.
Okay, now we will start.
Sure.
Okay, I will share it right now. Is it clear for all of you?
Yes, perfect.
Okay. Now we will start our presentation here. So our objective for this lecture, we will know what is the subarachnoid space and know what is the definition of the subarachnoid hemorrhage. We'll know what are the causes, the risk factor, and also the epidemiology for this disease. And also we have to know how is the presentation of the patient to our ER with spontaneous subarachnoid hemorrhage, how to diagnose it. We have to know what is the complication, and we have to control and manage this condition and know the real treatment for this. At the end, we will know some facts about the brain aneurysm and simple quizzes. We will show it as demonstration for a teaching way. Okay, now we will start. Here, as we all know, the brain is a highly socialized organ located inside our skull and surrounded by the meninges, as we see here, the pia mater, the arachnoid matter, and the dura mater, right? So when we're going to talk about the subarachnoid space, it's mean the space that's located between the arachnoid matter and the pia mater. So when we're going to say there is subarachnoid hemorrhage, it mean what? It means there is subarachnoid here in this space, bleeding or hemorrhage between the pia mater and the arachnoid mater. Is that the full definition for the subarachnoid hemorrhage? No. So let's to know together what are the causes for the subarachnoid hemorrhage, right? When we're going to talk about the subarachnoid hemorrhage, we can categorize them into two categories. The first one is the traumatic subarachnoid hemorrhage, which is the most common cause for subarachnoid hemorrhage, from head trauma, RTA, and etc. But it's not the title for our subject today. So what is our title? It's the spontaneous subarachnoid hemorrhage, right? We choose this title because it comes with different presentation, with many complications. And this one, the spontaneous subarachnoid hemorrhage, come from many causes. The first one, the most important one, it's count like 85% of the spontaneous subarachnoid hemorrhage. It's intracranial ruptured aneurysm, as we see here. It's like 85%, maybe 90% of the spontaneous subarachnoid hemorrhage. And maybe there's other causes like arterial venous malformation, tumor bed, cerebral arterial dissection, drugs, and etc. for the causes, right? So now we know it's the spontaneous subarachnoid hemorrhage come mostly from the ruptured aneurysm, right? So what is the ruptured aneurysm? What is the intracranial aneurysm? We're going to talk about the aneurysm. It's mean that there is a weakness in the blood vessel wall, maybe artery or vein, almost artery. And this weakness will lead to a punch, like a balloon, like a ball, like extravasation of the vessel. This punch, like we see here, named as aneurysm. And the aneurysm has many types, or we can say or classify it according to the shape, like we see here, fusiform aneurysm, saccular aneurysm, and this saccular aneurysm or the berry aneurysm, it looks like the sac, right? This one, maybe it will rupture, this one mostly the ruptured one, and lead to the ruptured aneurysm that cause that subarachnoid hemorrhage, right? Here we will see this angiogram of a saccular aneurysm here, other angio for the for the fusiform aneurysm. And here for this picture, we will show and demonstrate some of the physiological point about the aneurysm. We maybe use it to know the basics of the aneurysm. The aneurysm usually will be with the blood flow direction, as we see here. This is the blood flow direction, this is the aneurysm. It also being at branching point, we have to look for this point, branching point, also surrounding by small perforators, perforating artery, right? In this picture, we're looking for other saccular aneurysm in the angio, saccular aneurysm, fusiform one, and other pathological pictures. Now we know what is the aneurysm, which is the most cause or the mostly causes of the spontaneous subarachnoid hemorrhage. Now we will look for the classification of the sites of the aneurysm, the most common site for the aneurysm. When we go to look for the site for the aneurysm, let's do a quick revision for the circle of Willis that we also know. For the circle of Willis, as we know, here two vertebral arteries come here and to form the basilar artery, and this the posterior cerebral artery, and this also the posterior circulation. Here we have two internal carotid artery here in the bifurcation point lead to the middle cerebral artery here laterally, and here in the middle, in the midline, we look for the anterior cerebral artery, and which also communicated by the anterior communicating artery. So when we're going to talk about what are the most common sites for the ruptured aneurysm, we'll talk about branching point, as we said before, right? So the most common site for the ruptured aneurysm is here in the ACOM, anterior communicating artery, here in the anterior circulation. Maybe it will be here. For this demonstration, we see that 40% is the anterior carotid artery, like is the most common one, but the most of the resources said that is the anterior communicating artery is the most common site for the rupturing aneurysm or for the aneurysm. The second common site here, and the PCOM or the posterior circulation maybe. The third common site is here in the middle cerebral artery at branching point between the M1 and the M2, the first branch or the second branch of the middle cerebral artery. And then we will look for the posterior circulation. It's count like 10 to 15% of the percent of the aneurysm. Now we all know what are the aneurysm, where it should be located, what is the most common site for it. So who are at risk to have a ruptured aneurysm? Who are at risk to have a spontaneous subarachnoid hemorrhage? Let's to think about the vascular disease. As we know, aneurysm, it's a vascular abnormality, so it looks like the vascular disease, right? So what are the risk factors for the vascular disease? Maybe hypertension? Yeah, sure. Smoking, alcohol? Absolutely. Family history? Sure. Age, advanced age? All of that things, it's a risk factor for vascular disease, and also it's a risk factor for aneurysm, for formation of the aneurysm and for rupturing of the aneurysm. And there is other two really important causes or risk factors, we can say. Here, adult polycystic kidney disease and other connective tissue diseases like AHORA syndrome, as we know. And when we are going to say it comes from a family history or it comes from adult polycystic kidney disease, which is also a familiar disease, so there is a high risk to formation of what? Of multiple aneurysm. So when we look for a patient which have multiple aneurysm, not a single one, that we will have a prediction of maybe this one has a family history or familiar disease like adult polycystic kidney disease. And other risk factor, it's not demonstrated here in this slide, maybe the ethnic group, like in Finland, like in Japanese, they have high risk for the aneurysm and for the ruptured aneurysm, which will lead to the spontaneous subarachnoid hemorrhage, which is our title for this lecture. And here we look for this table. It's certified our talking here. This table talking about the risk factors of subarachnoid hemorrhage. And this is taken from medical emergency handbook, which is in Italy. Now, the most important things of our lecture to look for the presentation of the subarachnoid hemorrhage. How is the patient of the subarachnoid hemorrhage come to our ER, and we have to increase our level of suspicion that this patient has subarachnoid hemorrhage. The first important thing of the presentation or the sign or symptoms is sudden severe headache. It's important to sudden and severe. The severity, we can say it is the worst headache in my life. Maybe this patient have a series of previous attack of headache. He will say this headache is different. It is the worst headache in my life, and it's sudden. Maybe we will see in 50% of the patient, there is decreasement of the level of the consciousness. Why? It makes sense because there is increase in the intracranial pressure, and when there is increasement of the intracranial pressure, so that will lead to the decrease the level of the consciousness, right? Maybe we'll see a focal deficit. Absolutely. Maybe we'll see attack of seizure because of the irritation. Maybe we'll see a photophobia, increasement of the high blood pressure. Maybe we'll see oculomotor palsy because there is a compression according to the size and the site of that hemorrhage. And what we going to say else? Maybe we'll see nausea and vomiting, yeah, and maybe we'll see a fever. So nausea and vomiting, fever and headache, okay, photophobia, right, and neck stiffness, yeah. Nausea, vomiting, headache, fever, neck stiffness, photophobia, all of that come with the sign of meningitis. Yeah, this is meningitis. And this is the most common misdiagnosis mistake that we fall with a patient with a spontaneous subarachnoid hemorrhage, that we think of him as a patient with meningitis. And because we all know how meningitis is common and it's more commonly than the subarachnoid hemorrhage, so we fall in this bad diagnosis. And 50% of the subarachnoid hemorrhage patients will die after 1 month if left untreated. So if we go with this misdiagnosis and maybe using of antibiotics for many weeks, that maybe will lead to death of this patient. So how we can avoid this misdiagnosis? How we can increase our level of suspicion for this patient that he have subarachnoid hemorrhage? First, we have to look for the history. There is sudden severe headache. It is something happens suddenly, not something gradually. Like the meningitis, there is something come and there's something after it will come. Like, for example, nausea and vomiting. After that, we will see that fever, maybe gradually in onset in the increasement of the fever, and then we will see the neck stiffness. So the history give us the indication. The second thing, we will look for the age. Meningitis, maybe it will come with children, right? But for the subarachnoid hemorrhage, it's rarely come in the pediatric age group. Is that the way to avoid it? No, you have to send your patient for the non-contrast CT. Wait, you're saying to send this patient for the non-contrast CT in the emergency department, which is second line of treatment or second line of investigation in the emergency. Yeah. Here, with subarachnoid hemorrhage, there's exception to send the patient for the non-contrast CT, whatever it was the case, okay? So now we know how to avoid this misdiagnosis. So how to diagnose the patient with the subarachnoid hemorrhage? Yeah, as we said, we will look for the history first, and then we will look for non-contrast CT. Why non-contrast? Because we will look for the hyperdensity and the bleeding. So we will look for non-contrast CT, which it has sensitivity like 95%, and then we will see and look for the hyperdensity region or the subarachnoid hemorrhage. Then we will send the patient for the angiogram. And when you talk about the angiogram, maybe it will CT angio, MRI angio, catheter angio, whatever it was, but we commonly use the CT angio because it commonly used, fast and cost effective, and come in a few minutes maybe. So that's the angio to look for the exact site of this aneurysm and its size to decide the best treatment for it. There is 5% false negative in the CT. So the books said that we have to look for the LP, lumbar puncture. The lumbar puncture, we will get a sample and look for like this, blood, and here look like yellow. This yellow one, because it's look xanthochromia, we can say. This xanthochromia is come from hemoglobin destroyed to be a bilirubin, so it looked like yellow in shape. But this is not applicable in our daily practice, because as we all know, the LP, it's really invasive procedure. So we do our best to diagnose this patient of subarachnoid hemorrhage with this investigation for the CT and for the angio. Now we will look together and see how we can look for the picture of or the radiology of the patient with subarachnoid hemorrhage. I will suspect that the viewer that they know the basics of the radiology here. So this is axial section for non-contrast CT. Here we look for this black area, which is hypodensity. This hypodensity area, because it's filled with the CSF, because it's called the cistern. It's like a sac of a CSF. So we will look for this region. It's called the basal cistern. It's okay to know it's just the basal cistern, but if you want to get more advantage, here this region called the supraciliary cistern. That below it, it's called the anteropeduncle cistern. Here is the ambient cistern. Here is quadrigeminal cistern. All of that called the basal cistern. Here we will look here and here laterally on the both side. It's the Sylvian fissure, or maybe you call it the lateral sulcus. But it's the Sylvian fissure here we used in the neurosurgery. The Sylvian fissure, it's the way that the middle cerebral artery moves. Sulcus separated the frontal lobe from the temporal lobe here. And here in the midline, we will look for the interhemispheric fissure. All of that demonstration was a normal CT to look for the normal CT scan that demonstrate the Sylvian and the interhemispheric and the basal cistern. So now we have to increase our suspicion how it will look, that subarachnoid hemorrhage on the non-contrast CT. It will look like this, hyperdensity, star shape like this. This is star on the basal cistern filled with the blood, on the here for the Sylvian fissure, and here in the interhemispheric fissure. Interhemispheric fissure in the midline give us suspicion about ACON ruptured aneurysm, anterior cerebral artery aneurysm, because it's located in the midline, right? As we do the revision for the circle of Willis. This two sides, like the Sylvian fissure here, as we know, Sylvian fissure have the middle cerebral artery, and it makes sense, middle cerebral artery and the circle of Willis go laterally. And for the basal system, give us suspicion about the posterior circulation ruptured aneurysm, right? We look here, right, because we look for the left side, it means the right, hyperdensity in the Sylvian fissure give us indication about ruptured aneurysm in that middle cerebral artery. Maybe to confirm it, we have to look for the angio to confirm this this pathology, right? Other cases here, blood fold in the Sylvian here, and huge hyperdensity in the intrahemispheric fissure give us indication of subarachnoid hemorrhage. This one here, we are looking for another case here in Iraq and Baghdad Neurosurgery Teaching Hospital. Also, subarachnoid hemorrhage in the intrahemispheric and in the Sylvian fissure. Now, as we're talking about the subarachnoid hemorrhage radiology, so let's to look together to how to differentiate it from other subarachnoid, from other intracranial hemorrhage for the subdural or maybe the epidural hematomas. So, like we're saying, we are covering all the intracranial hematomas on the CT, which is really essential for us in the emergency department. So when we're going to talk about the extradural hematoma here, extradural, it's mean outside of the dura, and we all know the dura, it is the hardest part of the meninges that surrounding the brain. So when it will be extra of the dura, that means it will be have like clear margin, defined margin or line like this, because it will be cut by the dura outside, right? It will look like the lemon, we can say lemon sign, and it will be biconvex against the side, against the direction of the brain. Here is the brain, here, and it will be in this direction against it, right? So this is the epidural hematoma, and we're looking for the subdural hematoma here. We can say it will be subdural, so the hardest part of the meninges that catch the bleeding, it will be below it, so it will not be in defined margin or defined line like the epidural, and it will be like the banana sign, you can say. It will be like the crescent shape, and etc. So let's diagnose together how we can look for the pictures or the radiology of these cases. Here, it's non-contrast CT axial section here. We're looking for this hyperdensity area. This hyperdensity area, we can look for it. Clear defined margin here, right? Against the direction of the brain, and it's not like banana, we can say. So this is the epidural or extradural hematoma. Here it's, we can say soft tissue injury. We can look here. Here we look like clear margin and against the direction of the brain, and it not look like banana sign. We can come with the lemon, we can say, right? So this extradural hematoma, it is the most serious one because here it means it look on the temporal lobe. That is the boundaries of the middle cranial fossa. So that's here it look on the temporal lobe. And the most serious extradural hematoma located on the temporal lobe because it will do a pressure on inside our brain and inside the brainstem. That will lead to bradycardia. And here we can see that is subarachnoid hemorrhage also. Maybe there is a fracture here. All of these things shown in this case. Now, for this picture, we look here. It's not clear margin, as we say, because it's below the dura in the subdural region. It's not, it's come with the direction of the brain, right? It's come in this direction, right? So it's come with subdural hematomas. right? Now you have to ask yourself, what is this? And you will listen for the answer from me, like we are asking and answering. I will look for this one. It is, what you can say? I'm gonna say it's extradural hematoma because clear margin against the direction of the brain, and we can say biconvex shape, right? We'll look for this one. For this one, not clear margin, come with the direction with the brain, so it come with subedural hematoma, right? For this one, it's not like the other cases that we looked, right? Not like the subarachnoid, not like the epidural, not like the subedural. So it is intracerebral hemorrhage, ICH, right? On the most common site, which is the basal ganglia, right? So now we will show other demonstration. You have to ask yourself, now, what is this picture? What is this picture? It's come with our demonstration. It's not like the epidural, not like the subedural. Now we look here, hyperdensity here, come with a star shape, right? So it is subarachnoid hemorrhage. And maybe we look for hyperdensity in the intrahemispheric fissure and the sylvian fissure. So that's come with maybe ruptured MCA or ICOM. That's we will certify it with the angio, right? Now we look for this case. It's really a challenge here in the Baghdad Neurosurgery Teaching Hospital. 34 years old male came to our emergency department. The Glasgow was 11. He had a left side weakness with upper limb grade 0, lower limb grade, upper limb grade 1, lower limb grade 0. And we operated him in 11 hours. For this case, for this one, in ICH, intracerebral hemorrhage. But, we look here and we see that hyper density here, maybe it comes with the sylvian fissure. So we suspect this patient maybe have a ruptured aneurysm. And when we operate him for the ICH, we see, yeah, it have a ruptured aneurysm, and we did the clipping for it. Now, after we looking for the CT, so let's to look together for the angio. To look for the angio here, we will do the quick revision that we did before. But now, these are two vertebral arteries come together to form the basilar artery, right? And here we look for the posterior cerebral. This is the posterior circulation. Here is the internal carotid, the cervical, petrous, cavernous segmented here. And here we are looking for the bifurcations of the internal carotid artery, right? It's come here laterally, as we said, to form that middle cerebral artery with these branches, M1, M2, M3, and M4. And here we look for the anterior cerebral artery, right? And here is the ACOM, the part of the communication, anterior communicating artery, right? And this is the names for these arteries. Here we can see this punch, this case, real case here in our hospital. This is a ruptured middle cerebral artery aneurysm in the end of the M1 and the beginning of the M2. As we said before, in the branching point, which is the normal physiology of the aneurysm, right? Other CT angio from this section, we look here, terminal carotid, come here laterally, so it's come with the middle cerebral one, right? And we can look here, there is ruptured aneurysm in the middle cerebral artery. And we can see in other cases, another angio, and this case come with ruptured aneurysm. Here we can see hyperdensity in the intrahemispheric and in the sylvian fissure. We will confirm diagnosis or the specific site of this aneurysm and the size with the angio, right? Now, another case. This case has a multiple aneurysm. As we said, when we look for a multiple aneurysm, we have to look for what? Maybe this patient has, we can say, increasing risk of familiar diseases, adult polycystic kidney disease, because this abnormality come maybe with a multiple aneurysm. So here we look for this one and this one. It's not really clear demonstration of the angio, but we can say, I think it is the internal carotid artery aneurysm and the middle cerebral artery one. Now we know the imaging, we know how is the presentation of the patient with the ruptured intracranial aneurysm for our ER. We know how to diagnose him, how to avoid the misdiagnosis. Now we will look for how to do the grading for these cases. We have here two grading scales, which called the Hunt and Hess, H and H, and the Weffin. Will not come with the details of that things, but this grading scales come with good prognosis or bad prognosis. So when we come with a grade 1 or a grade 2, it means we have a good prognosis for the surgery. So go do the surgery, maybe do the clipping for it. And maybe grade 3, 4, 5, it means there is bad prognosis. So we will look for other options, right? For the grade 1, like here in Western, grade 1, it means the Glasgow 15, the best Glasgow. Grade 2, meaning Glasgow 30 or 40, 13 or 14, sorry, without neuromotor deficit. Okay. Grade 3, it means 13 or 14 with a motor deficit, and so on. That's how we can grading this aneurysm. And we're looking here with the Hunt and Hess scale. It's according to the presentation of the patient. If he was mild headache for like a grade 1, severe headache, maybe it will come with a confusion, focal deficit, and we look with the grade 5. There's disorbrate. It means brain death. So that means really bad prognosis for the surgery, right? When we're looking here in this table, the third grading scale is Fisher scale, and there is modified Fisher scale also. This grading scale, we look for the radiology, we look for the CT scan of this patient, and when we look for the CT scan, give us indication for the risk of one of the most common and one of the most severe complication of the aneurysm, which is the vasospasm. We will talk about it later when we're going to talk about that complication, but we have to know the Fisher scale give us indication of suspicion about the risk of the vasospasm, which is really serious complication. So now we finishing our scale. We will look for the complication. We put the complication here before we will talking about the treatment or the management, because we'll put our line of treatment according to these complications. We have to put in our mind there is two important, two most common, two most serious complications. We have to put it really in our mind, and the other complications we will look for it after that according to the case. The first one is the rebleeding, and the second one is the vasospasm. They are the most common complication and the most serious complication. The others, it look like making sense, right? Hydrocephalus, yeah, hydrocephalus makes sense because it's subarachnoid hemorrhage located in the cistern, so it's a sac of CSF, right? So it will be filled, so the CSF will come back to the ventricles, and with that, it will lead to the hydrocephalus, right? Hypertension, yeah, it's also come with these cases. Seizures, also because increasing of the intracranial pressure. There is systemic complication we have to put in our mind, like cardiac abnormalities, ECG changes, maybe looking for sudden MI, and maybe we'll see pulmonary edema or pulmonary embolism. Then maybe there is hypernatremia or hypovolemia, sure, because there is bleeding, so mean that hypovolemia. It's come with it, right? And look for the hyperthermia and sepsis. This according to case, and we will manage it according to the case. But we have to put in our mind the rebleeding and the vasospasm. All of our control and management, our treatment will be based on it. Okay. So according to this complication, we'll do all treatment and management. Control and management for this patient. It's not the real treatment, it is the control and management. Like we receive the patient in the ER, so we will try to save him and make him alive. Okay, it's not the real treatment, how we control him. We look for this slide and we see a huge lines, many lines, so let's to simplify them. First, as any patient come to the ER, we have to make the bed rest and administration for him. We have to make arterial line to control the hemodynamic circulation and for the hemostasis. We have to intubate the patient if he was unable to breathe or if he was unconscious, right? And then we will look for the most important things. This too, and the bold type of or style of typing. We have to do blood pressure control. Blood pressure control to make it below 140, right? This thing to prevent them or to manage, not the real prevention, for the most common complication, which is the rebleeding. Because it makes sense. When there is high blood pressure, there is high risk of rupture, aneurysm, and do the rebleeding, right? So we'll use this beta blockers, right? And then we will look for that nimodipine or nimodipine, which is calcium channel blocker. We will use 60 milligram per or with every 4 hours to prevent the second most complication, which is the vasospasm. But you have to be worried about the blood pressure, not to make it fall down. Look for the hypotensive, and then it means there is a risk of ischemia, right? Now we will look for the intracranial pressure. Maybe it will be increased, as we said. So there is many of monitoring for it. There is cardiac monitoring for it. If there is seizures, prophylaxis when it comes with a seizure, we can use analgesic and antiemetic drug that's come to prevent the increasement of the intracranial pressure and for the comfortability of the patient. Stool softening that comes to prevent the increasement of intracranial pressure. Antifibrinolytic that come with the maybe with prevent the rebleeding, and if there is hypothermia, hyperglycemia, we will try to prevent them according to these cases. Now we will look for the real treatment after we will prevent them. That is the practice guideline of the neurosurgery. Here, we will look for the most common two things we have to do is the administration using of the nimodipine, calcium channel blocker, using of the normal saline or and IV fluid, and control of the blood pressure. That is the most important things. Now we prevent the complication, we manage this patient, so let's do the real treatment. The real treatment is according to the real complication, is the rebleeding. So to prevent the rebleeding permanently, we will do securing this aneurysm. We will secure this aneurysm with coiling maybe or clipping according to the decision of the neurosurgeon, right? This thing will prevent the aneurysm rebleeding, right? That is the practice guideline. Talking about the time of the surgery, the time of the surgery have to be as possible as you can in the first 3 days. And if you can't do it in the first 3 days, you have to wait to the 3rd week because there is a high risk in this period of time for the vasospasm intraoperatively maybe, and this will lead to ischemia and death, okay? For that decision, if it's clipping or coiling, it's up to the surgeon decision. And there's many of things considered in our mind, like the Whiffen or the H&H scale. If the grading scale was poor, like 4, 5, come not with the clipping. If it's come with middle cerebral artery, so that's good prognosis for a clipping. And if it come with elderly age, like above the 70, that's come maybe with the coiling. It's not our job. It's the job of the decision for the seniors and for the surgeons, right? Now we'll look for this case. Real case, we are operated here. Dr. Samer Haas operated with Dr. Anwar Nouri here in our hospital. Ruptured MCA in the bifurcation, and we can look here. There's hyperdensity in the sylvian fissure, right? And this is the angio for this case, how it look on the angiogram, really saccular aneurysm. This picture in the OR for this clipping. Here is a picture for me when I was on real aneurysm cases here in Baghdad, the neurosurgical teaching hospital. We can look here. for the clipping from above, from here. And this one is or our video. We can see how we can do the clipping here. It's a permanent clipping, but I just wanted to show how I will demonstrate how to do the clipping for this aneurysm. Okay. Okay. Now we will now here for the last slide is in our presentations. For now we secure the aneurysm, so we prevent the rebleeding. Now we will look for the prevention for the vasospasm. The real prevention for the vasospasm is the triple H. Triple H is mean H and H and H. Hypertension, induced hypertension, hypervolemia, and hemodilution, normal saline. So you can say hypertension, induced hypertension, it's mean increasing of the blood pressure that give us the risk for the rupturing of the aneurysm, of the rebleeding. But we do that after the securing of the aneurysm. It's mean we prevent the rebleeding permanently. So now you can to prevent the second complication, which is the vasospasm. There is a huge bad practice here to doing this triple H before securing of the aneurysm to prevent the rebleeding. So we have to do this after securing the aneurysm, and also we will use again the nimodipine or the nimodipine. And here is the practicing guideline talking about that things. It's also come with our talking, hemodilution and increasement of the blood pressure, and maybe to prevent the vasospasm, we will do this angioplasty. Other guideline to this other guideline decision, sorry, to prevent the complication. This one is come with the seizure prophylactic. If there is seizure, you have to use a seizure prophylactic anti-epileptic drugs, right? And we have to use it in short term, and some of the decision will be with a long term. If there's previous attack of a seizure, there is intracerebral hematomas, and there's hypertension, etc. of the causes. It's up to the surgeon decision, right? If there is hydrocephalus, if it was acute, the guidelines say you have to do EVD, external ventricular drainage. And if it was chronic, the guidelines say you have to do a shunt, peritoneal shunt, right? Now it's our last slide here. If there is one of other rebleeding management or for prevention, it's antifibrinolytic drug therapy. Maybe we can use it, but is the most important one to control the blood pressure and secure the aneurysm. Okay. Now it's the last slide here. We show MCQs, which is the most important things we have to consider in our mind, to stick in our mind. What is the most important presentation of the SAH? We will look all of that, the real presentation of the SAH. But the most important one is the sudden severe headache, the worst headache in my life. What is the best treatment of the rebleeding? All of antifibrinolytic therapy, yeah, it's treatment, but it's for the prevention, not real treatment. Clipping for grade 5 wasn't, no sure, it's bad prognosis. Triple H, it's come with a vasospasm. Clipping or coiling according to the case, yeah, it's this one. Control of the blood pressure, that's for the prevention before that real treatment, which is the surgery. Now, this is my final message here. 30 years old male presented to our department with the vomiting, meningismus, all the sign of the subarachnoid hemorrhage, and we see that there is increasement of the urea and creatinine. So we diagnose him with a multiple aneurysm. One is ruptured and one is not. So we will look for his CT, non-coterminous CT. We look here, there is hyperdensity area, right? Maybe in the sylvian, in the interhemispheric fissure, and so on. So we suspect that he has familiar disease like acute polycystic kidney disease, right? Because there's increasement of the urea and the creatinine. We look here for the angio, yeah, 2 of aneurysm in the ACOM and the middle cerebral artery also. When we send him for this investigation, we look like this, huge adult polycystic kidney disease. So that's come with our presentation to increase our level of suspicion. Now, we can say we're finishing our lecture. Why we are doing this lecture? We're doing this lecture because I'm really interested in this specialty and this department. And also, as we see here, this one, Emily Clark, that just movie, also have the ruptured aneurysm here. And here how we demonstrate when she was on the hospital, manage her well and do everything's good. So she prevents the death, and she is with us right now, right? So subarachnoid hemorrhage and the ruptured aneurysm, it's really severe cases. 50% of the patient will die after 3 months if we don't manage them. Maybe 10% will die before reaching the hospital. But if we manage them well, we treat them well, they will be alive also, right? I will stop the share right now. Okay, but I have another slide also. So my message here is we have to look for these cases, okay, and to prevent the death for many of peoples. And there's many of celebrities here, like Sharon Stone, Emily Clark, and this incredible guy. I didn't remember his name, but I know he's a comedian.
Quincy Jones.
Yeah, this one. Right. Also has a ruptured aneurysm. So all of these guys have a ruptured aneurysm. All of these guys suffering, but with a good management, now they are alive with us, right? So before finishing off my lecture, I have to really give a special thank, and I'm really grateful for this lab, Hose Neurosurgery Lab, the place that we learn, the place that we do a great simulation, the place that we have this opportunity from Dr. Summer. So there's a special thanks for Dr. Summer here. And I have to thank you all for the great listening, and thank you for you, Dr. John, for this great opportunity to share this lecture with all of you. Thank you very much. And now I will turn the lab.
Okay.
I will stop the share right now.
Okay, very good, excellent. You're
Thank
beyond the level of training that I was in medical school. Excellent presentation. And yeah, just click on the stop share there, Ali, so we can have some interaction here. Yeah. And I believe Samer's here. So just if you want me to, okay, I can boot you.
I will. Boot now you. I have to stop the share right now. Okay.
No, I do it. I'll do it.
Okay. You do it.
Okay. There you go. Yeah. Excellent. Let's go to the panel first. I believe is Samer here? He stopped in briefly.
Yeah, he's here right now. Yeah.
Are you here, Samer?
My colleagues here also.
Oh, great. How you guys doing?
Hello, Dr. John.
Samer, you've trained this gentleman very well.
Thank you.
He's better than me by far.
I'm sorry, Samer.
Hi, John. How is it?
How you doing, Samer? Excellent. I hope we continue this forever. The iRAQ Grand Rounds. Certainly, it shows well-educated students like that what they can do. Give a great presentation that's going to be on YouTube forever. So hopefully other students will take advantage of the excellent way he put that together.
Thank you, John.
Okay.
Actually, we have a new blood in the neurosurgery this year, and they are trying. They will keep on preparing presentation to be presented in the neurosurgical TV. This is the first time, and I'm really thankful for Ali for this nice presentation. I think with a very good accent, understandable accent for all. I hope that.
Yeah, I hope all medical students take advantage of it. Now, anybody have any comments or questions before I'm going to ask Samer a couple of questions? Anybody in the panel? I know what it's like to be a medical student. When I went to conferences, I was quiet. I didn't ask any question. Don't worry, this is your platform, and if you don't want to ask, that's fine too. I'm just glad you guys are here. Is that Anmar? There's a couple people on the panel. Ahmed, do you have any comments or questions for Ali? Ahmed, I believe. Go ahead, Ahmed. Are you there? I believe he may have stepped away. I have a couple of basic questions, and I'm not a neurosurgeon. Can you may have touched on this, Ali, about the demographics of a subarachnoid bleed between like women and men, and what ages they typically occur. What maybe Samar could help answer this question too. Is it more females and males that are prone to spontaneous subarachnoid bleeds? You're muted there. I can't hear you. Go ahead.
Now I have to answer, right? Subarachnoid hemorrhage, the female come more commonly than the male in 3 to 2%, like 3 female to 2 males in the subarachnoid hemorrhage. But when there is advancement of the age, when the age is come bigger, I think it will come with the male more, right? Maybe Dr. Samuel will confirm this.
Well, certainly they.
Female,
Go ahead, Samar. Go ahead, Samar.
Yes, mostly female, as you said, and with the advancement of age, person come closer to each other.
Mm-hmm. Now, what it can occur at a fairly young age. A significant portion appear at young age, correct, Samar? They can occur in the 30s and 40s.
The mean age for the subarachnoid hemorrhage is like 40 or 42 age for the subarachnoid hemorrhage, the ruptured aneurysm.
Mm-hmm. Okay. Now, I know this may be a little specific, but patients on anticoagulants, it's very common nowadays that the patients are on for heart problems, rhythm problems. And I'm sure there have been studies with arachnoid bleeds in patients on anticoagulants. Could you make a comment about that, Samar? Have you seen a lot of patients on anticoagulants that get these bleeds, or you really don't see too much of a difference between patients on anticoagulants and the normal patient population?
Actually, yes, you are right. There is a connection, maybe not a direct connection, with this type of hemorrhage, maybe other type of hemorrhage like subdural hematoma. One of the main causes is patient being on anticoagulant. But the rupture aneurysm, yes, it may facilitate the rupture or may increase the amount of bleeding. And actually, this lecture, John, I think you are the perfect person to ask, because the title of Ali was for non-neurosurgeons. That's the idea.
Well, I'm on 2 anticoagulants myself, and I worry that if I hit my head, I'll get a bleed. And I know there are other patients out there too that are on anticoagulants that kind of wonder about that. That they, because you'll have spontaneous bleeds from your skin, just from a wound. And so I'm kind of imagining the brain that might occur also. Well, another question, probably more for Samar than Ali. Now, did you mention it? Is there a genetic component to this? Does it run in families? There is a genetic component, right? You probably mentioned, I missed that. There is. Now, is it suggested that patients at high risk have kind of like preventative CTs at a certain age to see if they have them, like patients that runs in the family? I imagine it runs in some families. That is it suggested that they have a CT at a certain age just to see if they have it too?
There is certain recommendation for screening. We usually use the MRI for screening because it gives less radiation. MR angiography, you call it MRA, and it's usually recommended in patients with familial history of aneurysm, especially if more than one first-degree relative that will be a strong indication to do a follow-up MRI every 5 or 10 years or every new type of headache.
Okay, very good. Okay, anybody in the panel have any comments or questions? Ahmed, I know you were there before. As you know, there's sometimes connection problems, etc. Suhail, do you have any comments or questions? Possibly not. They're like me when I was in med school. I didn't ask any questions. I just blended into the background. Okay, great. Great. I really appreciate this. And it's going to be recorded, Samer, and we'll send you the edited version. And we look forward to seeing you guys next week.
Thank you.
Thank you.
Thank you.
Okay, I'm going to stop recording now. I'll stay on. Okay. Thank you, Ali. And thank all the students and panelists for coming, and especially you, Samer. Thank you.
Thank you. Thank you so much.
Okay, we stop recording. Hey, Samer, I got you some headphones, man. No, because they're great. You can be anywhere in the room, and you let me show you. And the sound is I don't know if let me turn the background off. Hold on. Let me. Okay, you see these headphones here?
Yes.
They're great because you can wear them and walk around anywhere in the room, and the sound quality is excellent. I'm gonna send you a set of these. Now, what is the best way? FedEx, or what is the best way to get something to IRAQ?
Actually, we have such wireless headphones.
What's that? Which way?
We have such wireless headphone. It's available, and I think we will use it next time.
Oh, okay. No, it's not a big problem. No, I heard everything fine today, but in the future, so you have a set like this, kind of?
Yes, all types.
All types.
Oh, okay,
Yeah.
Okay. I just thought I'd mention that, but you know, this is great. You know, Samer, what you did also with your series, I think that got a lot of interest. I just got back from Portugal, and I ran to a neurosurgeon that told me. She said, "When's Samer gonna do another series? You know how you put that series together on neurosurgical anatomy."
Yes.
So, and I understand from talking to Slaven, he asked me, he said, did Samer mention a series we're going to do? And that would be great.
I will try to start a series with Slaven, a different series. But actually, this is for me now the main project to support the new blood. And they are really interested, have a very nice English accent, and different different interest within neurosurgery. Some interested in researches, some interested in presentation. I think that will be more productive and more consistent for the future.
Yeah, the way it's structured is good because the people can watch the series. They can, if they miss it, and it's going to be on YouTube. And I mentioned to Ali, we have an app now. That show was on the front page of the app that Ali just did. People, all have to do is open the app, and it's there, the live presentation, which people don't know about yet. But everybody walks around with this damn thing. So, you know, if we can use it to spread neurosurgery education, and the way to do that is make it easy. You know, while you're in the hospital, while you're walking around, while you're taking a bite, boom, you tap it, boom, the live thing is right on the front page. So download that, Samer. Neurosurgical TV is free. And we're working the bugs out now. There are some bugs, but like anything, that even Facebook had bugs when they started. And, you know, these big platforms, you got to just work it out. And all you guys are welcome to download it and let me know, hey, Dr. Bennett, this isn't working. Or, hey, you know, I'd like to see this. Because what we want to do, Samer, is get easy links for neurosurgeons to tap, boom, they got it. Tap. and not have to type, so they just tap it. So, are you guys tired of me blabbing?
No, not yet.
Okay. No, well, we have an African grand rounds in a couple of hours from Cameroon. There's a journal club and there's 2 lectures. Let me throw it up there so you guys can see it. Hold on. So I'll do my part with presentations now. Hold on. Let me get that. Just give me a second. Okay, I got it. Sure. Okay.
John, do you need me?
Yeah, you see that? You see this? We have the journal club. This is 5 hours from now. A neurosurgeon from Morocco is presenting a specific paper on the journal club, and there's another medical student just like you guys from Cameroon that's presenting intracranial pressure monitoring. And this is the organizer, Ulrich. He's a medical student from Cameroon. He's doing a fellowship at Harvard, invasive multimodality brain monitoring, which I don't know what the heck it is, but he's going to tell us about it. So, you guys, if you know, you're welcome to come on the panel on any of these talks, and you don't have to say a word. You can just say, hi, I'm Ali. Nice to be here. I have no questions. I have no comments, because believe me, I was the same way, same way in medical school. So, okay, everyone, you guys have a good day. And I look forward to next week, and any comments, just send them to me.
John?
Yes.
You hear me? Just last comment. Maybe in the next weeks, we will do a successive every week for the next 3 weeks, I think. And after that, maybe it will be like twice monthly.
Okay. Yeah. Okay. That's fine. Just let me know. Just keep in touch and let me know, and we'll go ahead and do it. Okay. All right, guys. See you. Have a good day.
Thank you.
Bye.
Have a good day.